Welcome all to MycoClinics with a topic vulvovaginal candidiasis. Thanks for joining us, and we hope to have an interactive 1.5 hour with some great presentations. For those of you who have not been joining our MycoClinics webinars before, the format is that clinical experts will present a case study with diagnostic considerations, treatment deliberations, follow-up and outcomes, concluding with a discussion and literature review. During this session, please submit any questions through the Q&A, and your chairs today will use these questions for the discussions with the presenters after their lectures. I am Adilia Waris. I'm one of the directors of the MSc Centre for Medical Mycology here at the University of Exeter in the UK. And I'm chairing this session this afternoon with Professor Paul Verwij, Professor in Clinical Mycology, based at the Radboud University Medical Center in Nijmegen in the Netherlands. So our speakers are Professor Riina Richardson, who will present a clinical case of recurrent vulvovaginal candidiasis, followed by an overview by Professor Jack Sobel on new ways to treat recurrent vulvovaginal candidiasis. I just want to make use of this introduction to inform you about some other ongoing webinars. This is the Medical Mycology Trainee Seminar Series, so specifically for trainees, and we will have a link in the chat how to get more information about this seminar series. Another series we run from the MSc Centre for Medical Mycology is the Myco Talks, what are monthly webinars focused for scientists and mycologists, and the next one are already scheduled for the end of March and April, and some great speakers lined up for this. You can find more information on our website. And then the last thing I would like to bring under your attention, for those who are interested to obtain additional training in medical mycology, we run a course in a joint effort with the British Society for Medical Mycology in medical mycology, where the course can be done as a PG certificate, a PG diploma of a Master in Science. And also here you can find more on our website if you're interested in a program like this. Without further ado, I'm going to hand you over to my co-chair, Paul Verwij, who will introduce the first speaker.
Thank you, Adilia. Good afternoon, everybody. It's a real pleasure to host this session with you today. I think this is a really important topic of a disease which is a significant burden. If you look at it globally, it can be very persistent and recurrent, and I think also it is understudied. One of the fungal diseases which needs more study. So that's why I'm really happy that we really have two world experts who will present today. The first one is Riina Richardson, who is an honorary consultant in medical mycology. She's head of the service and clinical lead of the Mycology Reference Center in Manchester, and also senior lecturer in infectious diseases and medical education. So she's an expert in this field and wrote a very interesting review a couple of years ago on the global burden of RVVC. So today she will discuss with us a challenging case of recurrent VVC. Riina, please.
Okay. Many thanks, Paul, for the kind introduction, and time to get going with the topic. So yes, I'm presenting a case. I'm asking lots of questions to myself and answering them partially myself, but I think I'm leaving some questions to be discussed later on during the Q&A. So what does RVVC look like? What does vulvovaginal candidiasis look like? And don't be scared. It's not a bad clinical picture. It's my picture, how I see what it's all about. It's about angry mucosa. During my talk, every time you see this picture, it means it's an unhappy, angry mucosa. And that defines infection. So a couple of slides first, what we are talking about, so we are all on the same page. VVC is an infection of the vulva and vagina. A lot of the symptoms are actually caused by the skin reaction in the vulva. So it's a vulvovaginal infection. And it gives rise from colonization. This means it's tricky because a positive swab culture result does not mean infection. It can mean colonization. What decides if it's infection or not is, again, this angry skin, angry mucosa, as shown in the bottom. The clinical features of acute VVC include vulval itching, soreness, discharge, erythema, fissuring, and edema. All of these symptoms are actually non-specific. And the combination of these first couple of bullet points is tricky because if the symptoms are non-specific and swab result doesn't always clarify what's going on, making diagnosis can be very tricky. So the mucosa can be angry for another reason. It's hormonally driven. It's really rare in prepubertal girls and postmenopausal women who are off HRT, hormonal replacement therapy. You don't need any immune deficiency or any other risk factors. It happens in completely normal, healthy women. Damaged skin, so there are local risk factors. Damaged skin is a common contributing factor. And as you can imagine, having a recurrent disease, which is defined 4 or more episodes per 12 months, can have a massive impact on the quality of life of these women. This is so-called Casa-Deval curve. I'm sure many of you have seen it before, but just to summarize what it's all about. So it gives you the, visualizes the impact of the level of immune responses on the amount of tissue damage. So if you are an average person, it applies to many opportunistic colonizers, not just fungi or not just candida, but let's focus on the topic today. So if you're colonized with, you have a candida in your vulva vagina and you're a normal average person in the middle of the x-axis, that leads to colonization and no damage to tissue. And the weaker you get, the more you go to the left on this x-axis, the more you start to see tissue damage. It's caused by invasion of fungal cells into the tissue when the immunity is not fighting back. However, stronger is not better. The further you start going to the right, the stronger the responses are. You get to the area of hypersensitivity and overreaction to the presence of candida, and that leads to tissue damage again, without invasion into the tissues. From the same review article, there is a nice table summarizing a couple of examples, but let's focus on candida, which is highlighted in yellow here. As said, if with candida, you're in the middle, it's a commensal state. If you have impaired immunity, it can lead to disseminated disease. But also oral candidiasis requires some level of immune deficiency of impaired immune responses, which can be just the lack of saliva in the oral cavity in older people. However, if you go to the right and look at the strong response, hyperreactive, atopic type of patients, that's where you see your vulvovaginal candidiasis. This is sort of oversimplification, but it tells you about the picture, how VVC sets in the line of immune responses. And just really to confuse you finally, completely before the case, I just want to highlight that what happened to poor Candida when the genetic analysis revealed their relationships is very similar to what has happened to some families where they've done DNA analysis and noticed that you thought somebody was your sister or cousin and they aren't anymore. So 4 common Candida species here highlighted, and all of them have been redesigned a new genus, and not just that, but all of them in different genera, so not related at all. For the purposes today, we are going to stick to Candida and talk about candidiasis and ignore the genetic relationships that may be there. However, it is clear that they are different, and infections caused by Candida glabrata present slightly differently. Now, getting to our case. So we have Lisa. Lisa, the name has been changed and some details removed. So Lisa is a 36-year-old lady with a history of a period of RVVs in her early 20s when she was studying at the university. She's otherwise fit and well, but that's her history. She suffers from hay fever, and as a child she had asthma, but hasn't needed her inhalers for years. So sort of atopic kind of a person, sensitive skin. At the time when she was at the university, the flares were triggered by intercourse, and she was prescribed a 6-month course of once weekly 150 milligrams of fluconazole, which is a standard treatment for suppression of recurrences of VVC, and that kept her fully asymptomatic. And she was on combined oral contraceptive pill at the time. She completed the 6 months of suppression, and after that, for all these almost 15 plus years, she has only had occasional episodes which have responded well to the single dose of fluconazole, which you can get over the counter, at least here in the UK. So now she has been with her current partner for 4 years, and they got married 8 months ago, and they've been trying to conceive since. So she came off the oral contraceptive pill for 7 months ago, and not been successful yet. She has had 3 episodes of VVC over the past 5 months, and the last one did not respond fully to fluconazole anymore. Her GP, general practitioner, her family doctor, prescribed her a clotrimazole pessary, 500 milligram pessary, which slowly settled the symptoms. Lots of questions come to mind. So why has she started having VVC flares again? What's the trigger there? Why has she stopped responding to fluconazole? How can you test if that is caused by the clinical resistance is due to microbiological resistance and requires alternative antifungal treatment? Or if it's something else, maybe it's an alternative diagnosis, a skin condition, something completely different. Or there is a second thing going on at the same time. What do we do next? To answer the first question, why has she started having VVC again? Well, in most cases, you don't need any specific risk factors. You can't identify them. It just these periods of recurrency, they just come and go. They have a mind of their own. It's really important to make clear to the patient that it is not sexually transmitted. And that often comes to mind. They are actively now having unprotected sex, trying to conceive, and the thinking very quickly is that she's getting these flares because she's getting it from him. No, it gives rise from her own colonization, but it's true that during intercourse, Candida may get rubbed in and introduce the inflammatory cells, and that triggers flares, but it's not sexually transmitted. Risk factors, yeah, many have been identified. Estrogen is one thing, and pregnancy is a known risk factor for recurring VVC. Atopy, eczema, dry skin, yeah. Physical damage to the skin. Intercourse can cause that, physical activities. Poorly controlled undiagnosed diabetes. She's not pregnant yet, but diabetic control can be difficult during pregnancy. Immune suppression, obviously, and some iron and vitamin D deficiencies. Yes, we need to look at these components, and many of them we know that are there. She's atopic, she has that background, she is trying to get pregnant, so some hormonal changes are taking place after stopping the contraception. The second question, why has she stopped responding to fluconazole? So we said already that the features, clinical features, are non-specific, and many things can be going on. Maybe it's all, maybe we are barking at the wrong tree. Maybe it has nothing to do with Candida. Colonization with Candida is very common in women of her age, up to 20%, even with culture-based methods, higher with molecular methods, and that doubles in pregnancy. And if the swab is doesn't equal to the diagnosis, how can you then test if the clinical resistance is due to microbiological resistance? What we recommend is a post-treatment sample. So you're given the pessary or the fluconazole tablet, and 2 to 3 days later, you do another swab. If it's negative, you know that the remaining symptoms are due to something different. If it's positive, you probably will pick up something which is resistant to the given treatment. This is from the BASH guideline published, the references down there. I've colored the table from that guideline showing the main 5 differential diagnoses for all the clinical symptoms. And you can see that, yes, the VVC column, everything is green, that those symptoms are typical and present, but there are other columns which are equally green, and particularly eczema, contact dermatitis, skin condition as such. But there are others, as you can see. So that is part of the problem. What is not included to the table is herpes simplex virus reactivation. It can also present similarly. Obviously, if you get proper blisters and that then you can tell the two apart. But sometimes there is this sort of tingling and very non-specific itch kind of feeling, and then the blisters break very quickly, and then you have sore mucosa, and that again can all be, it looks and sounds like thrush as VVC. Importantly, the bacterial vaginosis is not a differential diagnosis. It presents very differently. But obviously, patients can flip between recurrent bacterial vaginosis and recurrent vulvovaginal candidiasis from one to another between treatments. This is just extension of the same table, more symptoms, and you can see that clinically you cannot really tell them apart, and taking a full history is really important. So what do we do next? So firstly, whatever the cause is, the cornerstone of all vulval symptoms is good skincare. So if she's using any soaps or wipes or shower gels, she has to stop using them. The skin is very fragile and thin there, and it doesn't tolerate any paint strippers or detergents like that. Instead, should use an emollient cream as a soap substitute for personal hygiene. And it also moisturizes and acts as a barrier cream if you sit in the shower, and keeps your shampoos and other things out of the area. In patients with so the guidelines say that in patients like her, the careful review of daily hygiene routine is really important, and that cannot be highlighted enough. You don't have to tell her to avoid sexual intercourse, but it is wise to advise that you cause less damage if you use a water-based lubricant. All guidelines remind women to avoid tight clothing and non-breathable fabrics, and particular use of panty liners or incontinence pads in slightly older women. These are, the skin needs to breathe, and anything that stops that is just not good for health. So are there any further investigations we should do for Lisa? So no additional investigations are routinely needed, but in this kind of cases, the screening, you may want to think about and rule out diabetes, obvious deficiencies like iron deficiency, vitamin D deficiency, but in some parts of the world, like in Manchester, UK, it rains every day, everybody's vitamin D deficient. So instead of measuring it, you just tell them to start your cod liver oils or whatever vitamin D supplements. We do sometimes test for mannose-binding lectin deficiency, and that is not to be it doesn't change management in any way. There is no replacement treatment if you diagnose it. It is the part of the soluble innate immunity, one of the three pathways of complement activation, solely to recognize fungi. And deficiencies in that pathway often lead to some sort of recurrences and more risk for superficial fungal infections. For some women, it's emotionally important to know that, there is a reason for this. I'm not doing anything wrong. I'm not eating wrong things. And to calm them down and say, it's a feature, this is you, and it's okay. It's important to tell them that it's not sexually transmitted, and not a marker of an STI, but in other settings, it's just obviously normal to offer an STI screen, including HIV screen, but it's important how we put these forward for the women, because you can cause a lot of emotional damage by bringing the whole sexually transmitted infection topic into the picture unnecessarily. So how do we treat infections like hers? Azoles are first line, but this is very important. Oral azoles must be avoided in pregnancy, at risk of pregnancy, and when breastfeeding. And every time we prescribe these for women of that age, we must check contraception and discuss it. So Lisa is prescribed clot trimmers or pessaries, and she can repeat it 72 hours apart twice if needed. It's not complicated, not too messy, and it's fine, unless you have a big belly when you're pregnant. Reaching down there can be tricky. All goes well with Lisa. Lisa gets pregnant and unfortunately then starts having flares of her symptoms every 2 to 3 weeks. She started on once weekly 500 milligram clotrimazole pessary suppression, which actually settles her symptoms. But Lisa has concerns of the safety of the suppression during pregnancy, and she's also worried about if the untreated VVC would be a risk for the pregnancy or for her baby. So the question is, what do we tell her? Well, you can read the details about the safety of clotrimazole pessary in pregnancy. It is safe and it's fine. You can also tell her, and this is a very nice systematic review showing that asymptomatic vaginal candida colonization does not cause adverse pregnancy outcomes like miscarriages or any issues for the baby. So needing to control the colonization to a point, but to treat any infections, that's plenty. It's safe. Now Lisa's pregnancy moves on and she's managed, everything is okay. She's using her once weekly pregnancy pessaries, but she thinks that they have stopped working. She's sore and she's worried and she's very pregnant. And she's still hoping to have vaginal delivery and just wants to get the infection under control. Vaginal swab was sent for culture and reported now with Candida albicans resistant to all tested antifungals. So what do we do now? So there are non-nasal therapies only available off license, at least in the UK, and they need to be reserved for proven azole resistance and non-albicans Candida species known to be resistant to azoles. So we have nystatin pessaries and boric acid pessaries available. However, boric acid is potentially teratogenic and should not be used during pregnancy. Nystatin pessaries are used and have been used in this type of situations. If she ends up with pre-labor rupture of membranes PROM, you can consider IV echinocandins at that setting, but that is up to the neonatologist. Lisa has had enough. She's very pregnant. She's just so tired of all of it. She is convinced that the vaginal delivery is not a risk for her baby, but she just wants to finish the pregnancy and have a C-section. And that is done and all goes well and the newborn is healthy. She then completes a 2-week course of nystatin pessaries and her symptoms settle. All is fine. That's the end of her symptoms for a good while. She breastfeeds for 4 months and has then a hormonal intrauterine device, so basically a coil, like my Riina coil, put in place when her baby is 5 months old. But a few months later, she has another flare of VVC symptoms. What are her options now? Will this ever end? She's desperate. So we are still in the situation that you can treat with nystatin as you did after delivery. Or now you can also use boric acid pessaries. Treat for 1 to 2 weeks. You can start suppressive therapy with once or twice weekly nystatin pessaries as an option. And keep things under control. Antifungal creams, particularly those with hydrocortisone, can thin the skin and ideally should be avoided. But now it's time to focus on skin care, strengthening the skin, providing the barrier function for it, and getting basics back in place. Some women benefit from antihistamines, particularly those who are very atopic, and if the flares start to happen, for example, during the spring, summer, when they are having more hay fever symptoms anyway. But again, if complete control of symptoms cannot be achieved, you have to think, is there something else going on at the same time? And we're back to this, that a post-treatment sample collected a couple of days after completion of the treatment can be very, very useful deciding what is actually going on. So these are the two options that we have. Uric acid has it slightly, has its own limitations, but broadly speaking, very well tolerated. But are there any alternatives? Some women think they are messy and not that nice to use, and for on long term, particularly a couple of days a week, having something coming out, it's not fun. So what is the role of other licensed systemic azoles like voriconazole or itraconazole? Well, in our experience, extremely rarely indicated or beneficial. You need to have the MIC testing done, and maybe they work, you can try. But again, have to be sure of contraception. There are two new antifungals, which Jack is going to cover after me. And they have FDA license for treatment of vulvovaginal candidiasis. So that sounds very, we are very much waiting for these drugs to appear to be approved in Europe. But again, these would be contraindicated in pregnancy. Obviously now she's not pregnant, so you could do it. So what further interventions are important? Well, we know that combined oral contraceptive pill can trigger RVVC, but she's not on one. And the risk with this hormonal coil is relatively low. However, HRT is associated with increased risk, but she's not there yet. There is no evidence to support the treatment of her husband around this. It is not the source of infection, it's her own colonization. And there are lots of other dietary guidance you may find in the dark corners of the internet, including garlic and honey and who knows what. There's no evidence of their benefit or any other fancier things. And particularly topically used can cause a lot of irritation. Better not. This is again from the guideline, just what the auditable outcomes are. I think it's really important to note that that one of the things that you have to audit when you look at your patient outcomes is whether you've done vulval skin care and discussed it on every visit. So, summary. How do we manage a patient like Lisa? The first question is it really VVC or RVVC, or is it only VVC? Is there dual pathology? Do they respond to treatment partially, so that there is probably a second problem? Temporarily, they did respond, but it comes back quickly, or not at all. Very different scenarios, very different explanations for them. Do they respond to the treatment microbiologically? What do they do with their skin care? Is there any risk factors there? Can we improve that? Are there any triggers like intercourse, and what can you do about them? What you need to tell your patients that it is hormonally driven, and it's nothing that they do wrong. And skincare is the cornerstone, and you can definitely reduce the frequency of flares and how quickly you respond to the flares when they happen. It is not sexually transmitted. It's nothing they do wrong or their partner has done. There is no magic diet they can start doing or avoiding something, and which women often try in desperation. And really, if microbiologically effective therapy does not resolve the symptoms, fully look for secondary or alternative diagnosis. We have just completed in our trust vulval skincare information leaflet. Happy to share this. It can be uploaded or whatever if you want. It's not yet on our website, but happy to share it, which is simple language for women to what to do with their skincare and how to improve skin health and reduce flares. That's all. Thank you.
Thank you, Riina, for this very interesting case discussion with many, I think, interesting aspects regarding the diagnosis and management of this infection. So I see that a few questions are coming in, so please feel free to ask questions and we will address that after the presentation of Jack. So let's move on then to the second speaker, Professor Jack Sobel, who is a professor of medicine and infectious diseases at the Wade State University Medical School in Detroit. And he has worked a lifetime on vulvovaginal candidiasis. He has published many research papers in this field. And also written reviews and guidelines. And I think many of us have consulted the guidelines which he has presented. So it's a pleasure to give the floor to Jack.
Thank you, Paul. Let me just share my slides, share my screen. There we go. Okay. That's right.
Is it okay?
Share what?
Auto recording there. Yep.
Wait. Share.
Yes. And then click on the screen. And then you can move the slides with your right arrow. Okay.
Okay, so everybody sees my slides, right? Okay, so let me start. So I'm going to start off with a heavy emphasis on treatments. And my title is Complicated Candida vaginitis. So in order to talk about complicated, just a brief definition of uncomplicated. So uncomplicated, by far the overwhelming majority of episodes of acute Candida vaginitis are uncomplicated. In other words, they are mild, moderate attacks. They are sporadic, less than 3 per year, occurring in otherwise healthy women without any predisposing, obviously underlying factors. And worldwide, the treatment is dominated by oral fluconazole. It is generic, inexpensive, remarkably safe drug that's been available for 30 years. It's clearly dominated. And whether we prescribe 1 or 2 or 3 tablets is a function of the severity of the attack. Well tolerated, but not used in pregnancy. There has been a mild increase in fluconazole resistance, and we'll discuss this in greater detail in a minute. But the fluconazole resistance in the common pathogen, which is Candida albicans, is and remains rare and uncommon, except in select populations that I'll discuss in a minute. So we're going to talk about complicated Candida vaginitis, which refers to pregnancy, severe Candida vaginitis, recurrent or refractory VVC, and an abnormal host. With regard to pregnancy, it's simple, very simple. We do not use oral azoles of any kind. That applies to itraconazole, ketoconazole, fluconazole, and the new drugs that I'll talk about in a minute, that have just been released worldwide, although not quite worldwide. No oral azoles should be prescribed in pregnancy. And so we are left with using topical azoles, usually imidazoles, some of them are triazoles, and we usually prescribe them for the usual duration of therapy, nothing special about the dose and in pregnancy. So treatment is rather limited in pregnancy, and the newer drugs are not a solution. So as far as an attack of severe Candida vaginitis, where there's significant vulvovaginal swelling, erythema, fissure formation, then one must simply does two things. One increases the duration of therapy, and therefore, instead of treating with a single dose of fluconazole, one would use 2 or 3 tablets. No matter what the drug you choose, you increase duration of therapy. Duration is important for severity. And a topical corticosteroid applied to the vulva, and usually not the vagina, is very helpful and very useful and absolutely essential for severe disease. But we don't select drugs based on severity per se. Just these two measures, increased duration and adding a topical steroid, is usually more than adequate. So now we come to recurrent Candida vaginitis, which occurs in worldwide, affecting all strata of society, occurs in about, depending on the study that you quote, anything from 6 to 9% of adult premenopausal women during the reproductive years of their lives. And the whole management of recurrent Candida vaginitis depends on the species involved in causing the recurrent bouts and any underlying specific factors, which I'll discuss in a minute, and whether or not azole resistance is proven and established. So these are the 3 factors that are going to guide the management of recurrent Candida vaginitis: species, underlying causality, and azole resistance. Now, the overwhelming majority of women with recurrent Candida vaginitis, it's still Candida albicans. There are some regional variations in this, and there are publications, particularly in Africa and parts of Asia, where they've described increased non-albicans Candida species, a smaller percentage, but over 90% are still going to be due to azole-sensitive Candida albicans. So the moment you make a diagnosis of recurrent Candida vaginitis, you don't have to rush off and get a antifungal susceptibility test, but you must require speciation. You need to know the species of your yeast in a woman who has recurrent Candida vaginitis. And that's part of a routine that is service that is provided by the local laboratory, whether it's a culture method or now much more frequently, certainly in North America, this would be provided by one of the DNA or RNA types tests, the molecular diagnostic tests, which are a little bit more sensitive than culture. But the gold standard is still, for all practical purposes, regular culture per se. Now, in terms of the underlying cause, although Riina didn't discuss it in any great detail, you're going to, I have a very opinionated view of causation of recurrent Candida vaginitis, because one has to separate genetics from triggers. Triggers are often called risk factors. I prefer the word triggers because these are triggers that bring on an attack in someone who is genetically predisposed. There's ample evidence in the scientific publication community that this is a genetic disorder. I'm not going to spend too much time documenting all the evidence in favor of the genetic basis for this, starting from chronic mucocutaneous candidiasis, where it was unequivocally related to very demonstrable genes that were abnormal. But in otherwise healthy women, and these are the patients with recurrent Candida vaginitis, otherwise healthy women, the genetic basis is a series of polymorphisms that it's not a single monogenetic kind of disorder. It's not hemophilia. It's multiple polymorphisms that combine at multiple levels to result in increased susceptibility to vaginal colonization with Candida, as well as in setting the threshold for the immune response, the inflammatory response of the vaginal mucosa. So these are the two levels that the genes operate. They create the susceptibility. But depending on the polymorphisms involved, you need various triggers. The commonest, very common trigger would be the use of an antibiotic, and no antibiotic is immune from this complication. So antibiotics are a common trigger of a recurrent Candida vaginitis, and virtually all women with a genetic susceptibility will tell you that they take antibiotics and they never get an attack of Candida vaginitis. And there are many women who take antibiotics and never get an attack of Candida vaginitis, and that's because they were born with the right genes. Sexual activity is undoubtedly frequent intercourse. It's usually a frequency factor, and that may be the trigger in certain women. You can have 10 women with recurrent Candida vaginitis in 10 examination rooms, shoulder to shoulder, and you can identify different triggers in every one of those rooms. Dietary, very unlikely to be a factor in the causation of Candida vaginitis. Rarely you'll find some women who will define certain forms of carbohydrate, refined sugar excess as a triggering mechanism, but for the most part, not. Uncontrolled diabetes, yes. I do not perform a glucose tolerance test routinely on women with idiopathic recurrent Candida vaginitis unless they have other manifestations. The yield is extraordinarily low, and it's a waste of time to do that test. Exogenous estrogens are an important factor, and the reason why recurrent Candida vaginitis continues in women postmenopausally is because of the continued use of HRT per se. Corticosteroid use, both systemically and topically, a risk factor, but most of the healthy women we see with idiopathic recurrent Candida vaginitis, there's no excessive Candida use. In North America, especially in populations where you see lots of women who are at high risk for bacterial vaginosis, the commonest cause of recurrent Candida vaginitis is recurrent bacterial vaginosis. You do not control recurrent Candida vaginitis in that population until you control recurrent bacterial vaginosis. These are two very strongly interlinked infections. So they are triggers, and they vary from patient to patient. The patient that was described previously by Riina was an idiopathic process. She didn't have bacterial vaginosis. She wasn't using steroids. She hadn't used estrogen. She was not a diabetic. There were no dietary risk factors. Sexual activity may have been a triggering mechanism earlier on when she was attempting to become pregnant. And we didn't get a history of exposure to antibiotics. I don't think that was a factor. Her episodes of recurrent Candida vaginitis were related to her genetic susceptibility, and that needs to be explained to the patient. So as part of the management, one should attempt to spend a bit of time discussing triggers for these patients, avoiding unnecessary poorly controlled diabetics have to be controlled. Make sure they're not taking an SGLT type 2 inhibitor, which is now increasingly in type 2 diabetics, becoming a major risk factor for recurrent Candida vaginitis. Recurrent BV must be identified and controlled. If a woman gets recurrent Candida vaginitis every time she takes an antibiotic, then you can prevent the inevitable episode of Candida vaginitis that follows the use of an antibiotic by giving her a prophylactic fluconazole tablet, 150 milligrams with onset of the use of antibiotics, and probably 7 days later with termination at the end of the antibiotic course of therapy. For the most part, we do not routinely screen HIV because it's unless the patient has other risk factors, it causes more anxiety than it's worth at all. So for the majority of patients with recurrent Candidiasis, it's caused by C. albicans. It's azole sensitive. The standard of care that was determined 21 years ago in an important paper at the time was you start off with an induction or loading dose of fluconazole, 150 milligrams, given one tablet every 72 hours, because you can maintain a concentration of fluconazole in the vagina above the usual MIC for about 72 hours. So there's no point in giving it daily fluconazole. You give it every 72 hours, you complete your loading regimen with three doses, and then you put them onto a maintenance regimen of 150 milligrams weekly for 6 months. And this is now the standard of care worldwide and has been shown in multiple studies. Although there are some variations, there's nothing carved in stone. So some doctors are using 100 milligrams once a week. Others are using 200 milligrams. There's some variation, and there are different specialists all over the world who have variations around this fundamental scheme, but it's really very arbitrary. So as is seen in the slide, as long as the patient is taking the weekly fluconazole, it works by preventing recolonization. This is the culture status of the patient. You start off with in an acute attack of Candidiasis, which initiates your plan to give her a long-term regimen, and you start her on treatment with a loading dose. As symptoms go away, the cultures become negative. And as with each dose of the fluconazole, she remains culture negative. You're not curing her genes, however. And so as long as she's taking the fluconazole, by preventing recolonization, you protect her from the inevitable breakthrough infection. As soon as you stop the fluconazole, as you compare it to the placebo, you see the attack rate, it picks up. And usually within the next 6 months, she's going to have a recurrence. Why does this happen? Remember, fluconazole doesn't cure an abnormal gene or genetic susceptibility. All it's doing is it's preventing recolonization. So what you are doing is you are providing her with a control regimen. And you'd explain to the patient what the risks are when you stop the fluconazole, so what do you do if it comes back? While they're taking the fluconazole, 100 milligrams, 150, 200 milligrams once weekly, more than 90% will remain attack-free, and they have a whole new lifestyle. They are free of symptoms. They bless you on a regular basis. We do not do routine cultures because the culture rate is markedly diminished, and you don't accomplish anything by doing a culture. And neither do you need to do liver function tests on a routine basis before or during, because it's really very, very rare that you're going to find abnormalities. Remember, you explain to the patient, you're not curing her. Don't make the mistake and say, I'm going to give you fluconazole once a week for 6 months and I'm going to cure you. You're not curing her. You're not curing those genes. You're giving her control. After you discontinue fluconazole, there will be a 40 to 60% recurrence rate in the next 6 months. It tends to decline the attack rate with the decades. So if you look at studies that have done comparing recurrence rates after cessation of fluconazole, every decade it tends to decrease from the decade of the 20s, 30s, and 40s, and even especially in the 50s, until the women go back onto hormone replacement therapy, and then you get back into the decade of the 30s. What do they do if they recur? Most likely, once more, you get a species from your culture, and as long as it's C. albicans, you restart your induction and maintenance therapy. And now there are no studies that tell you the optimal duration of therapy. We discuss this, I discuss it with my patient, and as a general rule, we continue for another year. Once a week for another year, patient remains asymptomatic, still blessing you, still very grateful, and still asymptomatic. And there's no good evidence that the initial regimen that is used during the 6 months of the initial control of therapy is going to determine what the recurrence rate is. It remains high. Remember, you are not curing the patients by putting them onto maintenance fluconazole. You are controlling recurrent Candida vaginitis. So it doesn't matter whether you use itraconazole daily or ketoconazole daily, or these two new drugs, which I'm going to talk about in a minute, oteseconazole, Vulvovaginal, or abrixafungerp, or Brixafem. So fluconazole-resistant C. albicans has been rare. It's less than 5% in patients who have C. albicans. If they have a non-albicans Candida species to start with, that's another story, and that requires specialized therapy. We do not routinely do a susceptibility test on all women who have recurrent Candida vaginitis. We only consider doing a susceptibility test for C. albicans when they display clinical behavior suggestive of recurrence, of resistance. So what would make you suspect the patient has a resistant C. albicans, these rare cases under 5%? If the patient doesn't respond clinically, she's compliant, she's taking the right dose, and she doesn't improve, she comes back 2 or 3 days, as Riina said, after you've started the fluconazole, and she's remained symptomatic, she's still KOH positive, then you'd get a susceptibility test. Or if while taking the fluconazole once a week, she has a breakthrough infection in a compliant patient, you get a susceptibility test. So 2 reasons to get susceptibility tests: breakthrough infections in compliant patients and patients who do not respond clinically when you take a history and a physical exam. Once you have a resistant strain of C. albicans, most of these resistant strains, if you test and do the susceptibility test, you will find that they are resistant. There's cross-resistance to itraconazole and to ketoconazole. Some of them will remain susceptible to voriconazole, but that's another story for another day. One of the attractive options is that based on in vitro studies, these 2 new drugs, ibrixafungerp and oteseconazole, are very active in vitro against fluconazole-resistant strains. The MIC may go up a little bit, but they are still responsive. But there's very little published data on the use of these 2 drugs to treat fluconazole-resistant C. albicans patients. The tests in vitro are wonderful, but the clinical experience to back up their use is another story. Certainly worth a trial. But if you don't have ibrixafungerp, or you don't have oteseconazole, because it's not available in many parts of the world, we'll talk about this in a minute, oteseconazole or Vulvovaginal is available only in America, and then it's highly restricted. The FDA is highly restricted, so you're not going to be able to use Vulvovaginal or oteseconazole. And ibrixafungerp, they've stopped manufacturing at the moment because there's been a factory manufacturing problem. So this slide is redundant. You can't use ibrixafungerp. It's not available. It may work, but it's not available. And oteseconazole has too many restrictions. So if you actually have a fluconazole-resistant C. albicans, you're going to go back to using a drug that's been available for more than 200 years, going back to Joseph Lister, 600 milligrams daily, or to vaginal nystatin topically. These are your 2, or if you're fortunate, you may still have some response to turconazole or one of the other topical azoles, but you're going to be using any of these regimens on a very, very frequent basis because they do not last long in the vagina. So, but this is all you have as an option. The only exception to this program is if the women who have resistant C. albicans also have recurrent BV. Women who have recurrent bacterial vaginosis, the incidence of fluconazole-resistant C. albicans is double. It's somewhere just under 10%. We're not sure why bacterial vaginosis facilitates fluconazole resistance in C. albicans, whether it's simply an exposure phenomenon, in other words, they keep getting exposed to the fluconazole, or whether it's related to the microbiome itself. So no answer to that one. So let me talk about abrixafungib. It's all Brixafem. It's equivalent and similar to an intravenous drug called an echinocandin, being a glucan synthetase inhibitor. It works totally differently from an azole, and therefore the mechanisms of resistance. So here it is as a glucan synthetase inhibitor, and not working in the same way that an azole would work. And it's a sidle, just to summarize its activity, it's broad spectrum in vitro against lots of the species. It's active against azole resistance, Candida albicans, but not a lot of clinical data to support it. It's sidle in vitro in the test tube, which is wonderful. And what's very important, it is potently active at low pH, which is the normal pH in the vagina. It was initially considered very safe. In fact, in terms of its overall safety, very good. Has about a 20-hour half-life. But because of some questions about embryo toxicity, it's not to be used in pregnancy. So there were several studies done in North America, or actually in the United States, the Banish studies, that showed that a single-day regimen of 300 milligrams twice daily, each tablet is 150, two tablets in the morning, 2 tablets at night, but it's one-day regimen, was highly effective for acute Candida vaginitis. And it was then subjected to a 6 months study for recurrent Candida vaginitis, which I'm going to tell you about quickly. So in the acute Candida vaginitis studies, it was compared to fluconazole. Excuse me, it was mainly compared to placebo. The FDA does not require for a drug to be approved in the United States that it's compared to a drug that's already available. So compared to placebo, abrixafungib one-day therapy is highly effective and statistically superior to placebo for acute Candida vaginitis. In the studies where it was compared to fluconazole, just one small study, it was shown to be equivalent, although there were higher cure rates on day 25 to 28. In fact, unfortunately, those studies were not pursued, and they didn't follow those patients for more than 25 or 28 days. So the sense is in the average patient who has acute Candida vaginitis, who has the opportunity to get Brixafem when they start manufacturing it again, will it be better than fluconazole, 1 or 2 doses of fluconazole? And there's no evidence that it is superior, but it will be useful for certain kinds of patients. So then they tried it for recurrent Candida vaginitis. The patients were initially given fluconazole to get them into remission, and then they were put into a maintenance regimen, 1 dose per month, not 1 dose per week. Received monthly abrixafungib, one-day therapy for 6 months. And it was, not surprisingly, here's the study, after they took 3 doses of fluconazole, went into remission, and then took the 300 milligrams BID one day a month for 6 months. And they were statistically vastly superior to placebo, which shouldn't shock you. Whether it would be better than fluconazole once a week was never tested, so we don't know if it's better than fluconazole. If the patient has a strain of Candida that is resistant to fluconazole, well, certainly that would be wonderful. And this is just to show the superiority, the benefits. So I don't want to run out of time. So let's talk about the oteseconazole, also called Vulvovaginal, which has been approved in some countries for acute Candida vaginitis, and has also been approved for recurrent vulvovaginal candidiasis. The one unique, it is an azole. It is a very potent CYP51 inhibitor with high selectivity, so that it's much more selective than fluconazole, allowing greater concentrations to be delivered to the yeast, and doesn't have any of the same human toxicities, epithelial cell potential toxicities. This is actually out of date, this slide, because it was found to be potentially teratogenic, and it was not approved for use in pregnancy, as was Brexafemme, and it should not, and because of it has a very long half-life. This drug, instead of having a half-life of 16 to 20 hours, which fluconazole has, and which Brexafemme has, it measures its half-life in 120 to 160 days, not hours. So that it's an ideal drug for single-dose therapy. It's highly effective against the azole-resistant strains. And when it was used in one study that was published in the New England Journal of Medicine, it was found to be highly effective in preventing recurrent Candida vaginitis compared once more to placebo. The companies don't like to do studies comparing it to fluconazole. And so is it better than placebo? Vastly superior. It was remarkably effective. And this is just to show in the comparison study compared to fluconazole for acute Candida vaginitis, which was part of a sub-study as part of this, it was as effective as fluconazole, but not superior to fluconazole. Recently a study came out in the last couple of months from China, where they treated over 300 women with severe acute Candida vaginitis, and they compared fluconazole to fluconazole. For once, they compared the oteseconazole to fluconazole, and as you can looking at these statistical values in terms of the clinical cure rates at especially at day 28, and especially the mycological cure rates, this drug was superior to not only placebo, but also fluconazole. So finally, we've got a study comparing these two new drugs to fluconazole, one study. So the advantages of these new drugs versus fluconazole, let's just summarize. They're all contraindicated. Fluconazole, Brexafemme, Vulvovaginal, no better. Poor women in pregnancy are getting topical agents. But they clearly are going to be useful if you have an allergy to fluconazole, if you don't tolerate, you have side effects from fluconazole, or you have fluconazole resistance. So if you have C. albicans, what's the likelihood that you would need this drug or this drug? Probably about 10% of the time. So 80 to 90% of the women who have acute Candida vaginitis are going to be adequately served as long as they are tolerating and have no resistance to fluconazole. They both Brexafemme versus fluconazole, both single dose, but they're equivalent. And clearly, both of these drugs, oteseconazole and Brexafemme, are more expensive. Okay, so the big advantage with oteseconazole is that if you follow these patients because of their long half-life, assuming the patients do qualify to get the drug, in other words, they're not pregnant and they don't have reproductive capacity, and you give them the Vulvovaginal or the oteseconazole, because of the long half-life, you can prevent recurrences not for 6 months, but for up to 2 years. So I'll finish quickly by talking about non-albicans Candida species. And as you know, these are problematic species. And actually, there's some evidence of increased prevalence of these non-albicans species. But actually, what's more important is that certainly in America today, where they are predominantly sending swabs, not to the labs for culture, but they're sending the swabs for molecular testing. The poor OB/GYN gets an obstetrician gynecologist gets back a result of a species that they've never heard of. They suddenly get results back, Candida glabrata, Krusei, Parapsilosis tropicalis. It's not that it's more prevalent today, but they're now testing for it. And so all these species have much lower virulence. They are most likely to be commensals. And by that, I mean they're going to be innocent bystanders. They are all less, every one of them, with the exception of Candida tropicalis, are less susceptible to azole drugs. And because they are less susceptible, they're going to be harder to get rid of. But they're, most of the time, you don't need to treat them because they're innocent bystanders. What you have to do as a clinician in seeing a patient who has non-albicans Candida is you have to establish causality. Establish that it's actually the cause of the patient's symptoms. Tropicalis treatments, fortunately, they're all fluconazole susceptible, so you would treat for albicans, but it's less than 1%. Candida parapsilosis, more common than albicans, about 3 or 4 times more common. This has variable fluconazole susceptibility. If it's sensitive, according to antifungal susceptibility test, if it's resistant, treat it as for Krusei. And Krusei is a problem because it can be virulent. And it's predictably resistant to fluconazole. And it's we don't have enough information about these two new drugs, brixafungerb and oteseconazole. But in vitro, they're active against Candida Krusei, but we don't have clinical data to support that yet. We need to have that data merge. Some patients, some physicians will use a combination if they get Candida Krusei because it's resistant to fluconazole. They put the patient onto itraconazole or ketoconazole if it's susceptible, and they combine it with nystatin. So a commonly used attempt is to use combination therapy, itraconazole, ketoconazole, and nystatin. And so for the most part, what we are using in North America is boric acid, which is highly effective against Krusei, but not always. Candida glabrata, however, is by far the commonest non-albicans Candida. It is also the least virulent, fortunately. Very hard to get rid of, never causes vulvar disease. The patient has vulvar manifestations they don't have, then the glabrata is an innocent bystander when you find it. High failure rates, very chronic. It is most frequently an innocent bystander and frequently azole resistant. What do we do? And this is my last slide. We treat glabratas with boric acid, 60 to 70% success rates, approximately equivalent with daily nystatin. You can, if your susceptibility tests show that the other topical myconazole or clotrimazole or terconazole works, you could try that, but it's daily. Or if you're struggling and you really believe that the glabrata is causing the patient's symptoms, and this is uncommon. Most of the time, the glabrata is not causing the patient's symptoms. You could try fluconazole, flucytosine 70%. It's not widely available. It's expensive. Or you can try topical amphotericin or combination of the two. And there's a fair amount of good data to show that this combination is probably the go-to regimen if boric acid or nystatin doesn't work. Voriconazole, there have been 1 or 2 publications where it works. Not an easy drug to use, with lots of side effects. These two drugs have lots of activity, but we don't have data yet. So unfortunately, we still live in a data-free thing. So let me end up by summarizing in this last slide. Always confirm your diagnosis. Get to understand what's going on in your patient who's got complicated VVC. Get your Candida species. Always establish causality. MICs are useful, but only when you suspect resistance. And then once you've got your MIC, you identify your appropriate drug. As a general rule, you don't solve acute complicated Candida by having short-term therapy. Always use at least 21 days of therapy. And I never had time to get into it. But I'm going over time, Adela, so forgive me. I'll stop talking.
Thanks so much, Jack. And maybe you can stop sharing your screen so we can see the panel members.
Okay.
That would be great. There is still time for some discussion and answer. There are a lot of questions in the chat. We probably will not make it to answer them all. But I'm going to select some, and then Paul will follow up maybe with some others. I would like to start off with a question for Riina, asked by Mark Presnight. What is the reason why oral contraceptives predispose to VVC flares, but IUDs are less likely to predispose to VVC flares? Has that something to do with local versus systemic increase in specific hormones? Is that known?
So the the association is particularly with the combined contraceptive pill, not mini pill. And if you think of Mirena coil or similar hormonal coil, it's closer to mini pill rather. There is no fluctuation in the hormonal levels. So the association is particularly with combined pill, and that I think it explains it mostly.
Okay, thanks.
And the IUDs without hormone, like copper coil, are not associated with any increased risk.
Okay. Another question from Jonathan Lambourne here in the UK. Is there any role for susceptibility testing for topical azoles? And if so, do we have breakpoints?
Yeah, so
short answer, please.
Quick one. So the short answer is that there's no need to do it, because you think of the scale of MIC testing, it is what levels you see for systemic drugs in blood. But when you're talking about 500 milligrams of clotrimazole probably in a milliliter pessary, you're talking about 500,000 milligrams in a liter. Nobody can do, thousands of plates to dilute that far. And we know that if you push the levels high enough, eventually they will work. So the reality is that with clotrimazole, they often work against slightly elevated or even resistant, fluconazole resistant isolates.
So in those patients, you would try topical treatment.
Oh, yes.
Even if it's test resistant.
And that's what we advise our general practitioners, family doctors, because the clotrimazole is available. Nystatin and boric acid, you have to come to special services. But they, if they're desperate that they need to do something on Friday afternoon, that's what we recommend they try.
Yeah. So, and there's another question on the role of myconazole, because it was not mentioned. Is that something which is commonly used also?
It can be used. I don't think there is any difference between them. It's just what's available, what's cheap around what your pharmacy keeps. I don't have a strong opinion one way or the other.
Okay. And there's also a question on the involvement of drug resistance. So should you repeatedly test patients, and do you see that resistance evolves during therapy?
Rarely. That's interesting, because often we see almost treatment naive or very treatment naive people coming up with Candida albicans with fluconazole resistance. And at the same time, we have lots of women who've been on suppression for years, once weekly, and they don't develop resistance. So it's a combination of factors. And we only do susceptibility and culture if they have breakthrough infections. Why would you culture if they are fine?
Yeah.
Mm-hmm.
Yeah, it's interesting that the rate is actually much lower than in the oropharyngeal candidiasis,
yes,
where you do see an increase over time in resistance.
I think the difference is that there you have biofilms, and I don't believe that VVC disease is a biofilm disease. It responds to fluconazole, which it's not active against biofilms. So I think the whole biofilm setting changes things radically.
Okay, a question for you, Jack, from Duncan Wilson. You showed a correlation between bacterial vaginosis and antifungal resistant candida. Was that a clinical observation or was that in vitro MIC resistance, or maybe both? And any thoughts, are the bacteria changing the Candida being there as well?
So I published a paper about 2-3 months ago. It was, in December, excuse me, in which I reported the occurrence of fluconazole resistance in Candida associated with bacterial vaginosis. And in other words, we looked retroactively at about 30 or 40 women who had C. albicans, recurrent Candida with C. albicans, which was fluconazole resistance and high levels of fluconazole resistance. And 80% of them had recurrent BV. So almost all the women we saw with C. albicans, resistant to fluconazole, had recurrent BV. So what it is about the bacterial vaginosis, where there's higher colonization rates. If you do a yeast culture on every woman who presents with bacterial vaginosis, you will find higher rates of colonization with yeast and with Candida albicans, and often they get mixed infections. There's no question they get mixed infections. What it is about BV that facilitates and enhances the frequency of fluconazole resistance is unknown. I might add that if you look at the general literature, and there's no studies, and there's very little data about it. There is, if you look at the pathogenesis of fluconazole resistance in Candida, then a number of microbial peptides have been associated with enhanced fluconazole resistance. So if you think about BV and why is there an increase in fluconazole resistance, is it related to the host and the mucosal response, the pro-inflammatory response, which is very evident in bacterial vaginosis? There's a very well-described pro-inflammatory response, which is different from the Candida pro-inflammatory response somewhat, or whether it's related to the dysbiosis that you get in BV. BV has such profound dysbiosis, whether the abnormal microbiota are contributing to the development of fluconazole resistance is unknown. So we don't know. Worthy of study.
Yeah, there is another question about that, the role of the microbiome in the vagina and leading to VVC. But I guess that more research needs to be done on that.
Yeah, I have a PhD student who's now collected samples from about 500 women, and we have analyzed the microbiomes and controls and cases, and there are massive differences, and it's very complicated to analyze it. But it's always difficult. What is a chicken and egg? Is it that the host decides, the host immune responses impact the microbiome, or the microbiome triggers different host responses? And you can do associations, but causations is difficult.
So there's another question on the pathogenesis regarding the source of the Candida. If you have recolonization from the GI tract, or that you have persistent Candida in the vagina. Do we know that?
Yeah, so most of the time, many, many years ago, when we still used to do Candida typing, they haven't been typing papers for many years, several years. But we used to have a whole different variety of techniques to do Candida typing. Most of the time that women had recurrent Candida vaginitis, they retained the same type for some time. And most of the time it correlated with gastrointestinal carriage of Candida. So how much of recolonization is due to persistence in subclinically in low numbers that may result in negative cultures versus recolonization from an exogenous source, gastrointestinal or otherwise, is not known. Personally, I think both happens. I think some of the recolonization is due to the fact that you suppress the organisms, and if you as a very simple basic laboratory technique, if you take a test tube and you fill it with different concentrations of Candida albicans, and you take a swab and then you put it into the different concentrations of C. albicans, and you then swab a Savaro's plate. Once you drop below 10 to the 5 ml, to organisms per ml, you will find inconsistent positive cultures. Above 10 to the 5, it'll always be positive. So I think that when we treat, if one looks, if you do follow-up studies on Candida albicans in women who get treatment, they become asymptomatic, they become culture negative, the recolonization rate is rapid. It's usually within 30 to 40 days. But the recolonization frequency and rate is much more rapid in women who have idiopathic recurrent Candida vaginitis. They are more prone to recolonization.
Can I add one thing to that? I also agree. I think it's both. I think it's just so important to make clear, because there is this sort of, again, women take the burden on themselves, thinking they're doing something wrong, their hygiene procedures are wrong, and they wipe the wrong way, or they take baths, and the gut bug fungi get into their vagina, or is that evidence that they have anal sex, and all that. I think it's a relevant question to some point, and we don't know why it happens, and I think it's important to make sure that we don't get that sort of blame on women. The message has to be clear.
Thanks for that. Slightly moving to a different topic. There's a question, Riina, about the frequency of cross-resistance between fluconazole and other azoles like clotrimazole. Is that seen often?
So as I said, we don't do topicals, don't test susceptibility for topicals, because we would have to go to such high concentrations that it's just not, it would become porridge. But between, if you look at fluconazole versus itraconazole and voriconazole, those resistance rates, it's typically you first lose fluconazole, and then if you lose itraconazole, then the rest of them go down as well. But not automatically all of them. So fluconazole, and this is now albicans. Of course, for glabrata and others, it's different.
Okay, thanks. I'm looking at the clock, and I'm really sorry, but we have to finish off this webinar. Time is up, so to speak. I want to thank both of our fantastic speakers, Riina and Jack. Thanks for sharing your experience and your insights. I think we had a lot of interaction in the online environment. Thanks to the audience for all their questions and joining us this afternoon. And thanks to my co-chair sharing this session with me, and hope to see you at the next MycoClinics.
Thank you.